Assalamu alaikum class. Today we are going to discuss the part 2 of my lecture on screening for diseases. In my last lecture we have discussed that what is the process, what is the concept of screening, and how different tests or examinations are applied on an apparently healthy population to screen out the diseased population from the rest of the population, and this process is known as screening for disease. We have discussed that the early diagnosis can help us to apply the secondary prevention. We have discussed that the basic purpose of screening conduction for a disease is to buy lead time, because by the process of screening we diagnose the cases in an early manner, and then they undergo the diagnostic procedure in a quick way, and treatment is provided. Prompt treatment is given, so this delays the complication rate, this delays the associated comorbidities, and this also delays the process of death and other complications as well. There are different types of screening we have discussed in our last lecture: mass screening, high risk screening, multiphasic screening, etc. And we have discussed that how in different scenarios we apply different screening tests. Then we discussed that there is a criteria of a disease to undergo screening, and there is a criteria of tests conduction for the process of screening. We have discussed in detail that what are the criteria of diseases which can undergo screening, in which the most important is that the disease should be a public health problem. It should be associated with a diagnostic test. If the screening is conducted, then the treatment facilities should be there, and there should be a policy plan for the screening of the disease. The disease should not be rare. The natural history of the disease should be known, and by the application of the early screening test, the proper lead time is attained by this process, and then services are provided for the early treatment after the screening of the of that particular disease in the population should be given. So now we are going to discuss that what is the criteria of the test to be used for the process of screening. And we have already discussed that this should be very less costly, it should be inexpensive, it should be easy to apply. And I have given you the example that for the neonatal screening, just a 2-minute screening test of the congenital dislocation of hip can be applied, and a screening test can be done for the detection of the refractory error in the school population. These are very easy, these are easy to apply, they are simple tests. Screening tests should be acceptable to the population. If you want to conduct, for example, the vaginal examinations or rectal examinations to detect the vaginal cancers and rectal cancers, definitely it will not be acceptable by the population, because these are apparently healthy population and they are not suffering from any sign and symptom. So most of the times when you conduct screening tests which are invasive, the population does not accept these tests. Then the screening test should be a valid test. Validity means that the test should measure what it is required to measure. Fine. And then the test should be reliable. Reliable means when the same test is applied in different population or in same population in with different settings, same results should be produced. Reliability means repeatability of a test. Fine. It is also known as precision of a test. And then in the last, we talk about the yield of a test. And the yield means that these indicators of a screening test are measured in terms of sensitivity, specificity, positive predictive value, and negative predictive value. And when we combine all four of them, it means we are talking about the yield of a test. Fine. So, moving further, why the results become unreliable? we have to discuss this, that if the test is bringing bad results, or it is producing different values in different times, it means the test is not reliable. And why the test is not reliable and is not producing the same results, the reasons can be three types of the variations can occur. Number one is the observer variation, which can affect the precision or reliability or repeatability of a test. Another type can be biological variation, and the third type is known as technical variation. So let's go towards the observer variation. When we apply a screening test in the same population, and if the one observer is producing multiple observations, this is known as intra observer variation. It means the population is same, observer is same, but whenever the observer applies this test on the same population, it is producing different results. It means we are dealing with the intra observer variation, where the observer is only one and he is giving multiple type of observations. Fine. So what do? We take our average of those observations. For example, if an observer takes a blood pressure of a person, um, and it is 120 by 80 millimeters of mercury, and second time he takes the blood pressure of the same person from the same side, and this is about 125 by 90, and the third time when he takes the blood pressure, this is about 110 by 75. So what do for the repeatability of a test? We take an average value of all the observations. Fine. Then we have inter-observer variation. Inter-observer variation means that, for example, you have multiple type of observers who go into the same community, and everybody produces different results. For example, one observer measures the blood pressure from the right hand and in standing position. The other observer measures the blood pressure from the left hand and in supine position, and another observer measures the blood pressure in a sitting position, and all three observations differ from each other. So these are known as inter-observer variations. The variations are different in different observers. In intra-observer variation means the observer is same, and whenever he observes and applies the test, the readings are different. But inter-observer variation means that different observers are applying the same test on same population and their values are different. So to counteract the variation in the inter-observer category, what do? We standardize the procedure. For example, we will say that all the observers will take the blood pressure from the right hand and in supine position, and from the BP apparatus which has the mercury column in it. So we have standardized the procedure and we have standardized the method, so it will reduce the difference in observations between multiple observers. Another method which can reduce the inter-observer variation is that they should be properly trained how to apply the screening test. For example, in case of measurement of blood pressure, they should be trained that where the BP cuff should be applied, how it should be applied, how much pressure should be inflated, and how to deflate it, and which sound has to be given significance. So they should be properly trained while conducting the screening test. And if there are inter-observer variations, they can be counteracted by an independent assessment and then making a judgment to it. So whenever we apply a screening test in a population, the repeatability, the reliability, and the precision of that test can be challenged by observer variation. This observer variation can be of two types: intra-observer variation and inter-observer variation. And there are different methods to counteract them. For intra-observer variation, we have taken the average of all the observations as the mean value, And for inter-observer variation, we have to standardize the procedure, we have to train the observers, and still if there is a difference in the observation, then we have to make an independent decision. Repeatability and reliability of a test can be challenged by the biological variation. For example, blood pressure. For example, there may be change in the parameter. For example, if we are going into a community and we want to screen the population for hypertension, this parameter can change in the morning. It can change in the evening. It can change with the intake of salt. It can change with change in the routine. So the biological variation can produce variation in the test, and it can decrease the precision and reliability of the test. Fine. Another biological variation can be that the patient's perception change with time. For example, let's suppose we go into the community and we are asking about the um, pain which a person feels during the process of driving. Let's suppose in a long distance mileage coverage. So we will be using the visual analog scale, in which he will be perceiving that on the scale of 1 to 10, how he can classify the pain parameter. So sometimes he can say that I'm feeling the pain of 5 out of 10. Sometimes he can say 3 out of 10. So the perception of the patient also can change the repeatability of a test, because sometimes you perceive the test in a different way, and after a certain period of time your perception change and the patient's perception also change. So what do? We actually counteract for the biological variation. We regress. We do regression model. We apply regression model, and we only take the mean observation. Fine. So another important thing which can affect the repeatability and precision of a test can be the technical variation. There can be defective instruments. For example, you have gone into the community and some of the observers have got the instrument which is defective or has been broken. There can be defective calibration. Calibrations are different in different instruments, or sometimes the faulty reagents are being used in different labs, which can affect the which can affect the repeatability and precision of a screening test. So whenever we go towards the criteria of a screening test, we must give importance to all the parameters, and the most sensitive parameter is the reliability, which can be challenged by three types of variations, and we have different types of methods to counteract them. Fine. This is to show you that what is the difference between validity and reliability of a test. Let me give you an example of striking into bull's eye. And let's take this example. In this example, you can see that all the arrows or dots have been placed in different direction. It means actually the target was this. So this test which is being applied on the population in this case is not valid, because he has attempted almost 7 times, and only one time he has got the central position, which was actually the aim. So this test is not valid because it is not measuring what it should measure. uh, Actually, all the seven dots should focus the central area, but only one has reached there. So the actual target was the 7 dots in the center, and this test is not valid at all. All the observations which are made in this case are far away from each other. So it means this test is not valid, it is not targeting the aim, and it is not repeatable, it is not precise, because every time this is put in the population, it is producing multiple different types of results. Fine. Moving towards this test is not valid because it is not getting into the center. It is not actually getting what it wants to get, but it is a reliable test because every time the measurements are done, they give the same results. So in this condition, this is not valid, but it is a reliable test. In this case, the observations are close. They are not close enough, but they are close to the target. So we can say that this is a valid test, but this is not a reliable test. In this case, yes, this is a valid case and this is a reliable case. So actually, when we are conducting a screening test, we should always conduct those tests as a screening test which are valid. It means whatever they are supposed to measure, they are measuring that. And number two, they should be reliable, that whenever they are applied to different populations or on different people in different circumstances, they are producing the same results. So this is the target of a screening test, that it should be highly valid and it should be highly reliable and highly precise. Moving further, when we talk about the screening test, we say that the yield of a test should be high. The validity of the test should be high. So regarding validity, we and the yield, we measure different parameters which are known as sensitivity, specificity, positive predictive value, and negative predictive value. So these are the parameters. They are measured when the screening test is applied in the population, and whatever the results are produced, they actually give us the yield of a test which is applied in a population to measure the disease frequency in apparently healthy population. So moving forward, let me give you an example. This is a population, healthy population, and you apply a screening test here. After application of the screening test, you say that some of the people are diseased in this population and the rest are healthy population. So you divide the population into diseased population and healthy population after applying the screening test. Then for this population and this population, you apply the diagnostic test. The diagnostic test means it is the actually the test which truly separates the true positives and true negatives. Diagnostic test is also known as a gold standard test. It means its values are not challenged. So what do you do whenever we apply the diagnostic test on this population? Some of them in this diseased population will be actually diseased and some of them will be not diseased. So it means this population is that population which was wrongly labeled as diseased population when the screening test was applied. So are you getting me? We have applied a screening test on the population. After application of the screening test, we say that some of them are diseased and some of them are healthy. And after their division into diseased population and healthy population, we have passed them through a gold standard test or a diagnostic test. Now the diagnostic test reveals that there are certain people who are actually diseased in the diseased population which was labeled by the screening test. But some of them are not diseased. It means this population was falsely labeled as diseased population after passing through the screening test. But when we apply the gold standard test or diagnostic test on the healthy population, we get to know that some of them are diseased in this healthy population, which was actually labeled as healthy population after conducting the screening test. And some majority of them are definitely the not diseased population, which was predicted by the screening test. Fine. So how do we classify them further? We label them as diseased as A, not diseased as B. And then in healthy population who are diseased, we label them as C, and not diseased, label them as D. Fine. Moving forward, we have to make a 2 by 2 table again to calculate the yield of a screening test. Again, the methodology of making a 2 by 2 table is that the disease status is actually always put into the columns. And now the test status is put in the rows instead of exposure rate, which was put in 2 by 2 table while conducting the case control studies and cohort studies. Now the test has replaced the risk factor. So disease positive and no disease, test positive and test negative, A, B, C, and D, and the grand total in the columns and the grand total in the rows. Fine. So the ultimately the grand total will be A plus B plus C plus D. This is the same rule which was applied in the construction of 2 by 2 table of the case control studies and the cohort studies. So now what we do is that we will again label them. We will say that after application of the diagnostic test or the gold standard test, all those who were diseased in that population which was actually screened and labeled as diseased population by the screening test, they are labeled as true positives, because the screening test labeled them as diseased population, and after the application of the diagnostic test again they are diseased. It means they are true positives. But all those people who were labeled as diseased population in the screening test and have yielded that this population has not produced any disease, or they are non-diseased population, they are falsely labeled by this screening test. So they will be known as false positive, because they were given the status of um, positivity of disease falsely. In case of a population which was healthy population, and now this healthy population, if the screening test said that they are healthy and you after applying the gold standard declare that they are healthy, then it means the disease has revealed the true negative population. But if the population was labeled healthy after passing it through the screening test, and after application of the gold standard you have found disease in this, it means this is known as false negative, because they were labeled as healthy population but they are diseased population, so they were negatively labeled as healthy population. So this will be named as false negative. Fine. So what do? We apply these values into the 2 by 2 table and we start calculating the measures of tests for screening tests which give us the yield of a screening test. So the first measure is, or the first calculation we do is, we calculate the sensitivity of a test. Sensitivity of a test means the ability of a test to truly identify true positives amongst all those who were labeled as disease positive by the screening test. I am repeating, the ability of a test to diagnose all the true positives amongst all those who were labeled as diseased population by the screening test. So A divided by A plus C will give us this sensitivity in percentage. Clear? I will repeat, the ability of a test to diagnose the true positives amongst all those who were diagnosed as diseased positive from the screening test. Fine. True positives from all those who were labeled as disease positive by the screening test. So going towards the 2 by 2 table, all those who were test positive and disease positive, it means they are true positives. These are true positives. So the ability of a test to diagnose all the true positives amongst all those who were disease positive in the screening test are known as sensitivity of a test. Fine, which is A over A plus C. Let's move towards the sensitivity. Again, it shows if you have a 90% sensitivity, it means that 90% of the diseased people which were screened by the test will give a true positive and the remaining 10% will give us a false negative result. Fine? Okay. Moving further, what is the second parameter of a screening test? Second parameter of a test says the ability of a test to identify all those who were true negatives. These were true negatives because the test said that they are negative and there was no disease in them. So these are known as true negatives. The ability of a test to diagnose the true negatives amongst all those population which was labeled as non-diseased by the screening test is known as specificity of a test. And this is calculated by D divided by B plus D. I am repeating it. From this, the ability of a test to diagnose all the true negatives amongst all those population which were labeled as non-diseased after application of the screening test is known as specificity of a test. So you calculate specificity of a test by calculating D divided by B plus D into 100 into it gives results in percentages. So specificity, a 90% specificity means that 90% of the non-diseased people screened by the test will give a true negative result and the remaining 10% a false negative result. Fine. Okay, moving forward, assume a population of 1000 people, 100 have disease and 900 do not have the disease. This is the total population. After this, 100 has disease and 900 do not have a disease. A screening test is used to identify the 100 people with the disease and it revealed these results. Fine. So for this results, calculate sensitivity and specificity of the test and interpret the results. This is your assignment number 1. Moving forward, assignment number 2, EEG was conducted in a healthy population to find out the brain tumor in that population. The results revealed were shown in the table. Now calculate sensitivity and specificity of EEG for detection of brain tumor. This is your assignment number 2. Remember always, you cannot calculate odds ratios, relative risk, sensitivity and specificity, and positive predictive and negative predictive values, effectiveness of drugs until and unless you make a 2 by 2 table. And this 2 by 2 table has 4 columns and 4 rows. If you will not make 4 columns and 4 rows, your marks will be deducted. Okay. So now you will understand it better that all those who were tested positive and they were also diseased when they were passed through the gold standard, they are labeled as true positives. All those who were tested negative and after passing through the gold standard, they were found without disease, they are known as true negatives. All those who were tested positive but they do not have the disease after passing them through the gold standard, they are known as false positive because they were labeled positive falsely by this screening test. And all those who were test negative but they were diagnosed as disease case, they are known as false negative because they were labeled disease negative falsely. So rest is the row total and the column total and then the grand total. So the ability of a test to diagnose the true positives amongst all those who are labeled diseased is known as sensitivity. The ability of a test to diagnose true negatives amongst all those who were disease negative is known as the specificity of a disease. I think now the concept is more clear. So moving forward, we have to calculate the positive predictive value and the negative predictive value of a test. The positive predictive value of a test means the ability of a test to diagnose all the true positives amongst all those population which was tested positive. So now the positive predictive value will be calculated as A divided by A plus B into 100. And the negative predictive value says the ability of a test to detect all the true negatives amongst all those who were tested negative. So D divided by C plus D into 100 will be your negative predictive value. Sensitivity detects true positives among the diseased population. Specificity detects the true negatives among the non-diseased population. Positive predictive value calculates the true positives among all those who were tested positive. Negative predictive value calculates all the true negatives which were tested negative. This is the crux of today's lecture. So for you now, this is the data of a screening test which was applied in a population of almost 10,000, which revealed the following results which are shown in the table. And now you have to calculate the yield of the screening test. Whenever you are asked to calculate the yield of a screening test, you have to calculate all the 4 parameters: sensitivity, specificity, positive predictive value, and negative predictive value. Fine. So this is your assignment number 3. Okay, moving forward, another question. A survey was conducted on a population of 5,000 and Monto's test was applied. Results showed that out of 5,000, 3,500 were positive for Monto's test. Upon further inquiry, it was seen that 356 were AFB positive and those who were Monto's negative, 126 were also AFB positive. Identify study design, construct 2 by 2 table, and find out the yield of Monto's test in this population. Assignment number 4. Okay, moving forward. What are the effects of prevalence on the predictive value? Whenever the prevalence of a disease will increase, the positive predictive value will increase. There is a positive correlation between the prevalence of a disease and positive predictive value. There is a positive correlation between specificity of a test and the positive predictive value. If the specificity of a test will increase, it will produce more increase positive predictive value. There is a positive correlation between the sensitivity of a test and the negative predictive value. If the sensitivity of a test will increase, the negative predictive value will increase. You can get MCQs on this. Okay, what is yield? The amount of previously unrecognized disease that is diagnosed and now brought to treatment as a result of application of a screening program reveals the yield of that screening program. The yield of a screening test is determined while calculating sensitivity, specificity, positive predictive value, and negative predictive value of that test. So, what is better? Should we go for higher sensitivity or should we go for higher specificity? You have to answer me this question, that if you want to apply a screening test in a population, which parameter will you prefer? Whether you will prefer the high sensitivity of a screening test or you will prefer high specificity of a test. You have to give answer with justification. This is assignment number 5. Okay, moving forward, what is the relationship between sensitivity and specificity? Whenever sensitivity increases, specificity decreases. It means this is the ability of a test to diagnose all the true positives among a population which is labeled as diseased population. Whenever sensitivity increases, the false negative results increase. Because specificity means in a population, you want to detect all the true positives from the diseased population. So there are chances that you will falsely label people that they are negative. Moving forward, there is another association. We can see that this shows the patients without disease. This graph shows the patients without disease. And this is the graph which shows the patients with disease. Fine. And this is the threshold value which detects the people which overlap between the two. It means these are all true positives. These are all true negatives. And these are labeled as false positive and false negative. Whenever we will move this threshold value towards the left, sensitivity of the test will increase. The ability of a test to diagnose all those who are true positives will increase, because if we will move this line to this line, it means that all those who were missed here, who were actually diseased, will be now taken care of by the test. It means moving threshold value to the left will increase the sensitivity. And if we move this threshold value towards the right, it means we are now detecting all the true negatives. Means all those who were here and they were wrongly labeled as the diseased population will not be labeled as diseased population. So moving this line towards the right side, specificity will increase. Okay? Let's move forward. This is another prediction. You can see that these are the people who have the disease. They are labeled as true positives now. And these are the people who are true negatives because they do not have the disease. We have just interchanged the places. In this, here were the diseased population and they were the healthy population. And now we have moved it here. This is the healthy population. Uh, these are the diseased population and these are the healthy population. These are those who do not have the disease and these are those, the green curve shows the diseased population and red curve shows non-diseased population. And this is a screening test. Fine. Whenever we apply the screening test, so there are certain people who are actually disease positive, but they are labeled as false negative. And there are certain people who are actually negative, but they are labeled as false positive. So whenever we will move this threshold value to this value, then the sensitivity will increase. Sorry, when we move this value to this side, sensitivity will increase. And when we, because we are covering all this green population, and when we move this value to this place, the specificity will increase because we are covering all this population which was under the cover of true positives. So by changing the threshold values, we can change the sensitivity and specificity of a disease. Okay, let me give you another example. This is a population, and there we have applied a screening test which was highly sensitive, and it means it has detected all the true positives which were diseased. And this is the test. If it has a high sensitivity, then its specificity should be low, so it will be giving false positive results. Fine. And if we have a disease with low sensitivity, then then if we have a screening test with low sensitivity, alternatively it will have a high specificity. So we have to think that whether we have to deal with a sensitive test or a specific test. So again, this is the relationship between sensitivity and specificity. By changing the cutoff values, we change the sensitivity and specificity of a screening test. We have to make decisions as a researcher that whether we want to diagnose all the diseased population or we want to diagnose all the healthy population. If we want to diagnose all the diseased population, it means we want to be more we want to be more precise about detection of true positives. And if we want to detect all the healthy population, it means we want to be more specific rather than sensitive. By changing the cutoff values, we can change the sensitivity and specificity of a test. If the sensitivity is increased, specificity will automatically decrease. And if we increase the specificity, automatically sensitivity will be reduced. Another example. For example, this is the diabetic population and this is the non-diabetic population. This is the high blood sugar level, fasting blood sugar level, and this is the low fasting blood sugar level. Fine. So if we apply the threshold value here, then we are detecting the true value in which more of the diabetic population is diagnosed as diabetic population and more of the non-diabetic population is labeled as non-diabetic population because we have adequately addressed the threshold value. Moving forward, if we reduce the value of threshold in our screening test, then what will happen? That a large number of diabetic population will be diagnosed, but we will be falsely labeling the healthy population as the diabetic population if we will reduce our threshold. Fine. And if we increase our threshold value to this level, then we will be missing a large number of people who are actually diabetic. But this will be a more specific test because in this case, the healthy population is labeled as healthy population. And very few will be labeled as having a high fasting blood sugar level. So by changing the threshold values, we can increase the sensitivity and specificity of a test And as a researcher, you must know that which test you are opting for, whether you want your screening test to be more sensitive or you want your screening test to be more specific. There are certain decisions which have to be made. For example, in certain conditions, we do not want to miss even a single case which is actually diseased. So in that case, we need high sensitivity of a test. And in these cases, we need high sensitivity if we are dealing for the detection of the cancer cervix, cancer breast, cancer bladder, or all other cancers, screening test for the cancers which can be applied, because we want to detect all the true positives who are actually diseased by application of this test, and we cannot take chances that we miss even a single case which is diseased after application of the screening test. So we want to be using highly sensitive test. In certain cases, we want actually that we should be labeling the healthy population as a healthy population. So we want to be highly specific when we are applying our screening test. So in those cases, for example, if you diagnose a diabetes, and if you are missing some of the people who are actually diagnosed, but you want more specificity, then it will be okay to miss few of the diabetic people, because the consequences are not grave, or they will ultimately come to the population. In case of hypertension, in case of detection of the thyroid levels, in case of detection of the cholesterol level, we want to be using the tests or the screening tests which are highly specific. We can compromise on sensitivity because we do not want to falsely label this healthy population as a disease population, because if we will falsely label them as disease population, a high burden will come on the healthcare services. A large population which is actually healthy will be falsely labeled as disease, and they will go to the healthcare service provision for seeking the treatment. So in those cases, we want to apply screening tests which are highly specific, because we want to screen the healthy people out of the diseased population. So as a researcher, you have to make decisions about your screening test. So this makes an end. Thank you very much for your concentration. Hopefully, you will be submitting all your assignments by 8 o'clock in the evening. And if you have any questions, I'm available. Uh, Thank you for your patience. See you with the start of lectures on biostatistics. Thank you so much.